Thank you very much to the session, on fundamental issue, I think, of health and healthcare, global goods and health. We have a very distinguished panel. Thank you for being here today. I will just make a few introductory remarks, and then we will each give your presentations. We'll come up here, and then we'll have maybe something like 30 minutes for discussion at the end, depending how things are going. Very, very important topic. And I think we need to think about also, and I have been in the Chancellery for the last 10 years. I should say I was the economic advisor of Chancellor Merkel for the last 10 years. And now I'm back at the university, and I was also working in healthcare, but not as a main part, but I was heading up the vaccine manufacturing working group, the political part at the WHO, where we had produced a report also to the G20 last year about vaccine fairness and localized production, and a lot of things I think have happened. But I think there are basically three issues I like to raise. The first one is, of course, financing global public goods. I think we'll have a variety of views on that. That's, I think, an important issue. We have the fifth, which is something we had discussed also in the G20, which I think is now coming alive at the World Bank. We had a long discussion in the G20 on WHO versus the World Bank, and I think that's clearly very important. I think it has accumulated, that's what I hear from the webpage, 1.4 billion in September in terms of funding. That's clearly very insufficient. That's not there. So that raises also the question in terms of blended financing and public-private interaction and private role versus public roles, which I think is something you guys are very knowledgeable on, and that is something which I think is very important. I think these are two different worlds, the private world and the public world. And I think this is already a big issue for many years. We discussed it also in the G7 a lot, is how to bring these two worlds together. I'm interested in your views, whether we're making progress, because I don't think we're going to be able to do it without the private world, which is there. I think the second, so one is the whole financing part of global public goods, and I know there's a strong discussion on that, and it's in the words of Agnes, who's going to talk later, we are in a moment of truth on some of these issues. I think this is something you had put in the preliminary comments to me. I think the second issue is governance. And look, my 2 cents worth, when we did ACTA A COVAX and we worked on the manufacturing working group, it wasn't very well organized. It was very dispersed. They fall back into national, including, of course, Germany. I was also part of the German task force on vaccine production. I think the multilateral part of it was very difficult. There was all this trade issue. There was a high-level working group, which included also Excellency Madame Ngozi on the WTO. So I think we didn't do very well, was my view at the time. Maybe you have a different view on that. And I think that the homework now to do is, what can we do ex ante in terms of governance to prevent this from happening again? And I have some ideas on that, but I'm very interested to listening also to others. And the final issue, which I think is very important, and I think the representative from Africa has done some work on that, is since I'm an economist, is sort of the whole issue of health and healthcare and economic growth and development. I think that link is very important. I think, both on climate and on health, we have a development issue in the world. I think the West is sometimes criticized as having double morality and their own standards. I think we really need to do a lot more, both in climate, by the way, and in health, in terms of economic development and developing the rest of the world. And without that, I think it's impossible. So I think this link, I know there's a lot of research on this area, but the problem is often not the research, but actually getting it done in politics, of linking growth and development to the healthcare sector. I think that's a big issue, and I'm looking forward to the presentation. I think it's Stephen who has done some work, if I'm not misinformed on that. Okay, so there are three issues which I've been associated with, and not being that deeply involved as the speakers are. But I think those are, from my point of view, important issues. So we have 5 speakers. Let's try to stick to 12 minutes each. I will introduce each one of you very shortly. So the first one, of course, is Marisol Touraine, who is the chair of executive board of UnitAid, based in Geneva. She has been also former advisor to the Prime Minister, and she has been a Minister of Social Affairs, Health and Women's Rights in France. So very happy to have you here. The floor is yours.
Thank you very much, Professor Roller, dear colleagues, and ladies and gentlemen, dear friends. It's a real pleasure to be with you this afternoon in Berlin for this nice meeting. And I want to say that I was listening to the introduction by Professor Roller, and I was thinking that probably we are at a moment as important as 20 or 30 years ago when we began thinking about global health. Today we have to climb a new step and define a new model to approach and address global health issues. And 20, 30 years ago, we explained that if we wanted to provide health everywhere, we had to think and act globally. And I think that today we have to explain that if we want to provide and implement global health, truly, we need to think about global goods. And we need to ensure that the access to products, to organizations, will be guaranteed everywhere around the world. So in my perspective, what is necessary today to think about global health is to give us the means, the capacity to guarantee equitable access to health. Global health doesn't mean equitable access. I mean, global health is something specific. And now we have to talk more specifically about equitable access. And if we look at what happened during the COVID-19 pandemics, we have both reasons to be quite positive and optimistic about the capacity we had to address the issue. And we also need to be very cautious and understand that we still have a long way before getting to true equitable access to health. I wouldn't be so negative as you, Professor Roller, about ACT-A. UnitAid has been and still is involved in ACT-A. We are co-leader of the therapeutic pillar. And I was very impressed by the capacity we had to set up ACT-A, to organize it, to make it work in a few weeks after the beginning of the pandemic. And really, 2 or 3 years ago, if we had said we're going to have a massive pandemic, everyone will have to remain home, do you think that we will be able to set up an international response so that vaccines, therapeutics, diagnostics get to low and middle income countries? The answer would have been no. And so we did it. And for this reason, I think we can be quite positive. On the other hand, we have to look at the reality. The pandemic brought into stark relief the extreme inequitable access to necessary health care. Tens of millions in high-income countries could access to very expensive and very sophisticated treatments and techniques, while in low and middle-income countries, people were lacking oxygen, and which is not a very sophisticated treatment. And oxygen happened to be something extremely important. Many people who died, I mean, a majority of people dying in low and middle income countries because of COVID-19 died because of a lack of oxygen. That's something that we don't know enough and we don't insist enough. And that's, I want to say one word. So my first message is we now have to talk about equitable access if we want to be able to address the challenges in health during the coming years. UNITED has a long experience dealing with equitable access. It's a small organization based in Geneva, which has been able to think about innovation in innovative, with an innovative perspective. What do we say? When you have innovation in health, it's not useful if it cannot be accessed everywhere by everyone. You can have the most wonderful innovation. If nobody can access to it, it doesn't mean much, because of course people in high income countries can benefit this innovations. But what is important is to transform innovation in health into very concrete solution for low and middle income countries. And that's very simply put in very simple words. That's what UNITED does, to translate, to transform innovation in health into concrete solution adapted to the reality of the people, the countries, the social situation of low and middle income countries. We do it by breaking down the barriers which exist. And one of our specialty is, and that's a common good, a global good, one of our specialties is to lower the prices of the new products, to negotiate with the private sector. So we have a very intimate experience of the private sector. We know how to negotiate about intellectual property, about patents. We have created a specific organization to make this negotiation, which is a medicine patent pool. And we have a lot of very good results. I will give you a few. We test and treat cervical cancer for less than $1 in low and middle income countries. We provide HIV treatments in many African countries for less than $70 when it costs more than $10,000 a year in European countries. That's very concrete. And we negotiated with the private sector and private companies about oxygen during COVID-19, because we have been leading the oxygen task force. And so we have adapted the supply of oxygen in countries where you don't have, in places, not countries, places where you don't have electricity, for instance. What does it mean to provide oxygen, to supply oxygen, if you are not able to plug the machine into to get electricity? So we have implemented this model, which save lives, 100 million lives impacted every year. We save money, about $6 billion over the next 5 years, and we save time. Without our experience, the Global Fund, for instance, would need 3 more years to scale up its program. So what next, and what can we do now, saying that we of course have to learn from the COVID-19 experience, saying once again that it was, we can draw good and positive lessons, and at the same time consider that of course we still have a long road to walk before getting to the SDGs and to equitable access. From my perspective, I would insist on 2 priorities, even if, of course, many others exist. The first one is that we, even if I'm not talking about resources and money, but what I mean is that even if we had enough money, what we don't have, but even if we had enough money, we would have to insist on 2 points. The first one is that we will need a radical rethinking of the way medical innovation is financed. We have the relationship between the private and the public sector is key. We need the innovation. We need to supply innovation everywhere, which means that we need to discuss the pricing and the conditions of intellectual property. And the second element before coming back to that, is that we need to finance and invest in health systems. And here is the question of the fifth and the World Bank. Radical rethinking of the way medical innovation is financed means to invent new negotiations pattern for allowing a fair dissemination of innovation. We saw, public resources are massively invested in research and development of innovation. And we saw that during COVID-19 pandemics. If the governments, the rich governments, the high-income governments, had not massively financed research and development for the vaccines, we wouldn't have got this vaccine as quickly. The question is, since governments and public institutions invest for private research and development, what can they get as a counterpart? And my answer is we should think about exerting some kind of pressure on the private sector. The public institutions have to say, we invest public funds, but the counterpart is that we have to negotiate from the start the conditions of the access to the new products and to innovation in low and middle income countries. And I can tell you that this discussion is quite hard and quite difficult. And my regret is that the G7 countries have not had such a negotiation with the companies that produced vaccines during the COVID-19 pandemics. But still, if we want to have public goods, if we want to access, if we want the population of the whole world access to innovation, we have to implement that. And the second element, which is extremely important, is that we won't have a dissemination of health. We won't have equitable access to health without discussions, investments in health systems, which means empowering population. We work for the people and not only with the governments, but we have to work with the governments, but we have to set up systems which are able to be next to the people, where people live, with nurses and midwives rather than with doctors and high-level technologies. And here comes the World Bank. I really hope that the fifth will be able to participate to this effort, because I'm really convinced, and that's my last sentence, my conclusion, if we want to make progresses now, we have to think the link between innovation, equitable access, and health systems everywhere, all around the world. Thank you.
Okay, thank you, Marisol, also for raising that important issue of innovation. I think we discussed it many times in the G7, actually coming a lot of suggestions from the French side to do this more. But I think everybody did their own thing. We had the Commission negotiating things for Europe. So I think your point is well taken. I think interacting with the private sector here on terms of prices and other things is key. Let's move on to very happy Rajat Khosla, who's here from Malaysia. He's the director of the United Nations University International Institute for Global Health. He's got 20 years of experience in global health, equity, human rights. He's been advisor to the WHO, looking at the complex in terms of human rights and other issues as well. Raja, thank you for being here. The floor is yours.
Thank you so much, Lars, and good afternoon, everyone. It's really impressive that we have the space to have this discussion on the question of global public goods. Shifting gears a little bit from where Marisol left us, I would like to focus the next few minutes that I have to look at issues related to financing of GPGs, and more particularly on conversations around international cooperation for financing GPGs, and touch upon the question of architecture that we've been talking about and hearing in the last couple of days that we've had here. And in doing so, I'll be building upon something that Dr. Sukat and I recently wrote together in the British Medical Journal. But I'll do something slightly sneaky. What I will do is I will be raising some of the problems and issues, and she'll give all the answers. So it's a very good partnership. I just state the problem and she will give the answers. But without wanting to sound too facetious, I want to focus particularly on some of the learnings that we have had over the last couple of years, but also some of the challenges that we are all becoming very increasingly aware about. COVID-19 has exposed the detrimental effects of isolationist thinking and called for global health for first and foremost to be recognized as a global common right, and healthcare systems as a common pool of resources. But what does that mean is the question that I would want us to focus on. What it means is that we need to start thinking and rethinking about issues of both quantum of financing that we are talking about, but also the sources of financing for the GPGs and the structural changes, the shifts in power that are required. And let me say it, if we are honest about doing something about these GPGs. The topic therefore raises some fundamental questions and issues about the differences between public and private financing and the public and private provision of public services, public goods, and public institutions. If you look at the description of the session that we are part of right now, it talks about we need to develop collective arrangements for financing common goods for health, regardless of whether they are delivered by public or private sector providers. I think that's problematic. And I think we, over the next hour and a bit that we have together, I would want to collectively question that premise. Is there no difference between public and private provision of services? If there is one, then how do we bring a greater balance in terms of what we are trying to achieve? The current imbalance between public and private finance is an important issue that unfortunately rarely gets mentioned when we are discussing public goods or common goods. And I hope we can spend some discussion time that we have looking at those issues. But it also importantly has some rather profound implications on the issue of global governance and the architecture that we want to redesign and rethink. The recently concluded work of the GPI called for something which has been previously stated by other such discussions, and it talked about two things. The first was a need to, a call to generate the global public finance and public investment needed for the production of global public goods and services and for the funding of these goods. And the second was the governance and structural reform that may be required for us to do that. I don't think this room requires me to take you through what is a global public good and what it isn't. But the thing that I want to focus on is that the deliverers and beneficiaries of global public goods are diverse, including developing and industrial countries, poor and rich, and people from different cultures living in different ecosystems with different histories. Something that was talked about yesterday, and it is actually the framing of the last plenary that we will be having, that health is political. And the politics that we are talking about is asymmetric. It's not asymmetrical. There are issues, there are power imbalances, there are challenges that we have to confront if we are honest about doing what we are doing. Because what we are looking at, the interests, the concerns, the priorities, the preferences, they will vary and the cooperation will vary accordingly. We are often confronted with the challenges that this may reduce it to not the global common good that we are trying to aspire, but a tragedy of common nonetheless. But what is wrong with the present system of funding and financing, and this is where raising some of the challenges that confront us, the model of bilateral aid, which is fragmented and ineffective. There are studies that prove it far more eloquently than I can state it right now. But what is critical that comes out of those conversations is that development finance being largely donor-driven and non-transformative, but also the need to shift the language from a patronizing language of foreign aid to empowering multilateralism, of a common fiscal endeavor. And how do we do that? And what are the processes, what are the conversations that can actually help us deliver that shift that we are talking about, and a greater balance between public, private, and how do we achieve that? The GPI and others talk about the philosophy of right? Co-creation, co-contribution, co-management, co-benefiting, with the aspiration that all countries benefit, all countries contribute, all countries involved in the decision-making for securing global public goods, such as vaccines, protecting global commons. But what would it take us to get us there? The kind of international systems, rules and regulations, normative structures that we are confronted with are just not fit for purpose. Then what is it that we need to do from where we are to get to where we need to? There are suggestions in terms of the need for a global contributions budget line for global common needs that everybody pays on an equity-based format and pays towards, with the idea that everybody shares and everybody pays. But as we know, the challenges then we are confronted with become even larger when we then start looking at issues around governance and the architecture that we have presently to deliver on the commitments that we are making. The question, therefore, is how countries can work together to achieve these shared outcomes in the global public interest that require international cooperation to be secured. The UN Secretary General put forward recently what is called as our common agenda, which calls for a new global deal for international cooperation that can better deliver the GPGs we need, better protect the global commons we inherit. However, the one big challenge is the global financial architecture, which is presently structured and organized, makes it less effective for the GPGs to be delivered, but it actually acts as a barrier for the delivery of these GPGs. And then, therefore, I guess the bigger question arises what a new global financial architecture may look like. And some concluding remarks, and to leave it there for a discussion. Some of the underlying structural factors that limit the extent to which the global financial architecture can serve the GPGs range from uneven geometry of the global financial architecture to do much better out of the institutions and processes that are there, which some would challenge are decaying, but also changing the economic geography and the bigger issue of institutional trust. Can we really do it with the systems and processes that we have presently on hand? Therefore, the need for a global financial architecture overall is the imperative of our time. That does not mean we need to just junk everything and create a new and start anew. But I think what we need to do is to have an honest conversation where the gaps and challenges are, what can be done through the reform of the present, but where we do need to plug the deficit in terms of new institutions and new architecture that may be needed. And just to end with where Agnes and I concluded our conversation in this brief analysis that we presented, that there is no time to waste, and that we do need to start having honest and transparent conversations if we are going to achieve the transformative shift that we want to. Thank you.
Thank you. Just on time. I think that's an important issue, the global financial structure. We've been discussing it, by the way, in the G20 and G7 for years. And also with the leadership of the institutions, and to sum it all up, I think we all agree it needs to be done differently. We don't agree which way. So I think the UN Secretary General has made an important contribution there. Let's hope it will move in a positive direction. I'll be also interested to know a little bit more exactly what you want to change. I think that's probably, I don't know, maybe Agnes. But before we go to Agnes, we'll go to Dr. Shadi Saleh, who is the founding director of the Global Health Institute at the American University in Beirut in Lebanon. So welcome. He's again a distinguished academic career, both in Lebanon and in the United States, advisor to World Bank, WHO on healthcare financing. And has received the prestigious Welgi Award for Global Health Leadership in 2022. Welcome.
Thank you, Lars. Great to be here at the World Health Summit. I'm going to perhaps start with a non-shocking statement. which is that the global health system as it stands now is a failure. Okay, I think it was clear throughout COVID-19 that it's a failure. We keep promoting and saying that we're all for global health, but when the global health system came to the test of people needing that solidarity and equity in global health, the system failed, and it became back, it resorted back to being a national system. Who can get the vaccines quickly to their people by who's willing to pay more and who's bidding more. So that means who's left out of the bidding game? The poorer countries. How many people in this room are from low and middle income countries? Majority. So that's good. So I have a good audience, Lars, for what I'm about to say. Yeah.
10 minutes.
You have to talk to them. So I think there's a presentation. So I'm just looking here because there's a screen over here. So I'm gonna talk a little bit about specifically, global public health goods for health when it comes to LMICs, but I'm gonna zoom it a little bit into fragile settings and conflict affected settings. So basically, just to summarize most of you, there's no need to talk a lot about this amongst you, is that it's global goods for health are goods that provide benefits where no one country would benefit from it. So when we're talking about eradication of infectious diseases, when we're talking about disease surveillance and control, we're talking about research to develop a vaccine. In principle, these are global goods for health. The problem that we saw, and it was very evident when COVID-19, in the case of COVID-19, is that by September of last year, and approximately a year ago, 3% of people in LMICs, or specifically in low-income countries, had received only one vaccine dose compared to more than 60 in high-income countries. And we know that, right? This is a failure of a global health system that existed then, that we hope, as Rajat said, and Agnes would contribute, that this will hopefully, too much pressure on Agnes, but it's okay, that this will change. Now, just to challenge your thinking about what a global health good is, or the inequitable global good for health. Refugee health. I'm going to give you an example from just 2 countries of the world. You know that currently we have more than 100 million individuals around the world who are refugees, right? So vulnerable population, and their health obviously is a priority that is of utmost importance. The cost to each of those, so Lebanon and Jordan collectively, approximately 30 to 40% of their population are refugees. I keep giving the example that because I lived and worked in the US currently has around 300 million individuals. Imagine if you had an influx of 100 to 120 million individual refugees from Central and South America to the US, right? If you've watched the news, 2 weeks ago, the city of New York that has 8 million individuals, okay, 8 million individuals live in the city of New York. They had an influx of refugees for political reasons, mainly from southern states, of 17,000 refugees, 17,000. The city wanted to declare emergency. 17,000 over 8 million. Compare that to countries such as Lebanon and Jordan, where you have 30% of their population are now refugees. Can you imagine the burden? And these countries who are fragile by definition, now we're adding to their fragility even more. So in that context, fragility and conflict become a negative global good, or what is referred to as a global bad for health. One, because it's cross-border, so there's the globality aspect. Second, it satisfies the anti-sense definition of a global public good. Already the health of the receiving is that they already live a considerable proportion of them in fragile settings. And then becoming a victim of fragility does not prevent from someone else, as a result of being a refugee, also getting into a context of fragility. So it's this spiral when that happens. And I'm not talking about it only in the context of the of the Middle East and North Africa region. Definitely in Africa, it's an issue. In Latin America, it's an issue. It's what's happened with Colombia and Venezuela and others. So if you look at how many countries can be classified in those settings, you're talking about a big list of countries. However, more recently, as we know, Ukraine has been added to that list. And some interesting facts as a result of adding Ukraine, but we'll come back to that later. So what happened, I'm an academic, so we like to do models. So sometimes meaningless models, but still we do that. So basically, forced displacement, damage to healthcare infrastructure, decreased health expenditure, health workforce disruption, which are elements in a fragile setting. Add to that, that whole ecology results in overcrowdedness, weakened surveillance system, low immunization coverage. All of that means that there's a higher need for global goods for health and the lesser ability to be able to receive that. So basically, if we want to deliver global goods for health, we need to plan and respond to emergency. And basically, in fragile and complex settings, you do not have the infrastructure to do that. You want to expand vaccination programs. We have an outbreak now of cholera in Lebanon, right? So this is a huge, but how would you do that if medical equipments and medicines are inadequate in that country? Regulating the safety of medicine, promoting refugee health, but the infrastructure, the real bones on how to be able to absorb global goods for health is not there. Problem. It always comes back, and I think the way that this session was designed is in a smart way, which focuses on two things: governance and financing. And one of the main governance on why the global health system isn't working is because the governance does not make sense. Let me give you examples. The global funding agencies and recipients are concentrated in the global north, right? 70% of 40 grants go to high-income countries, 73% of Wellcome Trust grants go to UK-based activities, and so on and so forth. That doesn't mean that they do not have partners in low and middle-income countries, but the main entity is based in high-income countries. The second, the knowledge production and research agenda are dictated by the global north. And we know that. Look at the publication rates. Look at who writes the manuals. And only 19% of that is from LMICs. Now, I have to caution you and myself that I'm not saying this to blame high-income countries. I'm saying this to advocate and encourage us in low and middle-income countries to engage more in global health. So the pressure is also on us, equally on us, as with higher-income countries. Low middle-income countries and fragility and conflict-affected settings are not well represented in governance structures. So more than 80% of global health organizations' leaders are from high-income countries. Lastly, funding is reduced when the need is the highest. Look at what's happening in Yemen now with the funding. So just to summarize, from a governance structure, look at the geography of governance. So you have low and middle income countries who comprise 83% of the global population. The leadership in global health entities is 17%. High income countries is 17%, and it's 83%. Interesting statistic. So basically, the concentration of funds, knowledge, and governance are mostly in high-income countries, where most of the global health problems are in low and middle-income countries. Funding isn't, so we spoke a little bit about governance, funding. There's a need to re-engineer the system of funding when it comes to global health, okay? Because there are lots of funders, lots of donors with different agendas. So if I am a low and middle income country and a fragile setting, I have to now address or re-change what I do, my priorities, based on the funding priorities of the donors, correct? Which results in a confused system, which results in an ineffective and inefficient system, okay? So basically, how to move forward. The first thing is the governance. I keep saying it's governance, governance, governance. Secondly, there's a need to streamline the funding of international donors to specific low and middle income countries. The way there's, instead of just saying problems, I'm gonna perhaps say solutions, but most of the solution is with Agnes. But just to say one solution is that we have experienced in a country such as Lebanon that whenever there's diversion in funds and priorities, the system is lost. When the donors come and talk to one another and define with local players what the priorities are, the system is smoother, it's more effective, and it's more efficient, meaning the donors do not have to spend as much money as they were when the system was fragmented. There's a great need for fragility and conflict-affected settings to be involved in the decision-making and setting the priorities and giving at least the context. So my last slide, just to leave you with, so hopefully, numbers that you would remember. 70% of cases of epidemic-prone diseases are in fragile and conflict-affected settings. More than 60% of the world's child and maternal death happened in fragility settings. 81% of people experiencing food insecurity were in fragile and conflict-affected settings. And more than 100 million individuals were forcibly displaced in May 2022, and that number will go higher and higher with the Ukraine and others. So I would like to thank you for giving me the opportunity to talk to you and looking forward for the rest of the session. Thank you.
Thank you. Thank you, Shadi, for this modeling approach from an academic, but I think it was very clear. Okay, now we move to Agnès Sokut, who's a director at the French Development Agency, so very, very important. She also was a director for health at the WHO. She's very knowledgeable about Africa and having worked there also at the African Development Bank. Also, I read worked on labor dynamics, which I think is also an important issue, but not relevant for today. And she's the co-author of the World Development Report 2004. And yes, thank you for being here.
Thank you very much. And as you can see, there is absolutely no pressure on me, everybody having promised that I will give all the solutions. So I will actually start because I think the people who spoke before me have really given a lot of incredibly relevant argument to the discussion. I will really start going back to 2020 and that global experience that is probably the first time that all citizens of the world experience the same thing at the same time. It's the first true global experience. And when we talk about global commons, probably COVID-19 has been the very first time there has been a global experience that affected large and small countries, rich and poor countries, countries in every region of the world, countries that have a lot of natural resources or have little natural resources. Everybody was affected, and the world, which was already globalized economically and had gone through decades of economic globalization, became truly global, with the realization of every single individual on the planet that they had a problem that was common with all the others. And that's where we need to start when we talk about global common goods. And within that, the question of global public goods. And that will be my second point. This debate about global goods and global commons is a debate in which there is a lot of confusions on semantics. And we also hear the word equity. Global goods, common goods, equity, three different concepts. And the first thing, if we want to get to solutions, is we need to clearly identify what the problem is. And one of the difficulties we have is that confusion in identifying the problem. When we talk about vaccine equity, we use a concept that is not a concept about the commons or public goods. Because what is the fundamental for a public good is the fact that that there is no market demand and you cannot charge fees. It turns out we charge fees for vaccines. So in fact, vaccines in itself are not a global public good. What is a global public good is the research and development, and it is the information, and it can be the policies, and it can be some investments in global programs. But the purchasing of the vaccine, by definition, is not, because a lot of people during the crisis were ready to pay for that vaccine. Commons is really about market failures. And when we have a global market, then we have global commons because we have global market failures. And in fact, at the heart of the pandemic, when everybody was looking for vaccines, money was not the problem. There was actually ample money, and it's been increasingly demonstrated in the reports. Financial institutions, international financial institutions, national financial institutions have mobilized extraordinary amounts of money to respond to the crisis. What was the problem actually was a market problem, which is when everybody wants the same thing and the demand increases and the supply is not there, then you have shortage. And this is what we've been experiencing, and now we're looking at a problem that is that there was something that was very desirable, had some global goods and some common goods aspect to it, and we were not able to deliver it as a global community. So the first thing really here is about global experience and the sense of common destiny. That we are talking, when we talk about global goods, we're talking about market failures. We're talking about the fact that markets don't deliver, that the system that we have of production of medical products and the system that we have about building public health institution has not functioned in 2020 because it has not been built. And that there has been for a long time a confusion between the common good argument and the equity argument in building a global health architecture that was about equity. That was about purchasing through market mechanism products that were then distributed on the basis of a charitable approach or an equity approach. But it was not designed to respond to market failures. It was not designed to respond to a global public good or global common problem. And this is where this diagnostic that we failed in terms of collective action is a problem that was shown during the pandemic in an extremely brutal and evident way, because an equity approach which was mobilizing money to redistribute was not enough, because the money was there was money to purchase the products, but the products were not there. If we think now ourselves as citizens of the world, building a collective community, building collective action, then we need to think of the fact that we not only need a global market, which we already have, whether we need it or not. The markets are global, but we need some kind of global government. And we don't really have a global government. We don't have a global Ministry of Finance. We don't have a treasury, a global treasury. So we are using different multilateral institutions to substitute for the fact that we have global problems, but we don't have a global government, which is usually the way modern societies over the past 200 years have handled the question of collective action, market failures, and the need to invest in public goods and in common goods. So if we go back to what it is that we need to invest in that is really at the heart of the common good question, at the heart of the market failure question, there are 5 categories of investments that need to be made. And this is what we did with different colleagues, identifying these 5 categories: is policy and coordination, information, regulation, taxes and subsidies. That's about how you use public money to shape behaviors and markets, and population-based programs, which include vaccination programs, but also NCD programs, environmental health, animal health, which are these programs that address the market failures of health services. And when we look at the way we have framed this debate in the past, we've basically just looked at the issue of innovation in products. And when you look at the literature on global public goods, it's very, very focused on the question of products. But the point that has been really highlighted during the pandemic is that it's not only about products, but it's about the public health infrastructure. That even when products reach countries, there was a difficulty to actually get the product to people. Even before the products were there, it was difficult actually to mobilize information about the epidemic, and it was difficult to have evidence-based policy. So how do we move forward when we have this diagnostic that it's actually the public health infrastructure globally that failed? Is something that now we need to address as a matter of urgency. And with the debate on global goods need to move away from the question of more money to buy more products, which is an equity issue, and move to the question of why do markets fail and what are the institutions that we need to build to address these market failures. Not the institution that we need to build and give more money to buy products. That's 2 completely different questions. And when it comes to that, the logic is actually to think about somewhere, some public funding that is collective, that is global, and subsidizes the construction of this public health infrastructure. And in many ways, right now, the hope lays on the World Bank fifth to be that global funding source that will help countries invest in their public health institution, particularly the integrated surveillance institutions that we all need today in order to be able to face the looming threats that come with climate change, with antibiotic resistance, with biodiversity loss. COVID-19 is just the first of many crises to come. We need that public health infrastructure. So going forward, if we think about solutions, first, the global health debate, the debate that is at the G20 and at the G7, needs to shift towards a true agenda of building the global goods institutions. It's not about more money to buy products, which is the way the global health architecture was bought. It is about addressing the 5 functions. It is about investing in national CDCs, in national public health institutions, in national medicine agencies. It is about investing in animal health program, in environmental health program, in One Health programs. It is about addressing the information gap. And that is that public health infrastructure that needs to build, that requires a completely different global architecture, because this is not how the architecture was designed. So that is really the first action, is to shift the agenda towards those 5 functions that are the 5 core public health functions that modern governments have implemented in the richer countries and in emerging economies, but are still too weak given the size of the problems that are coming our way with climate change. And we know that. We know in my country, in France, we know in Europe that we were not prepared enough for this pandemic, let alone other countries who have much younger public health institutions. So we need to together embrace that agenda that we need to build that public health infrastructure. The second part is that public health infrastructure, is not limited to these 5 core functions, in the sense that we see that there are also failures in markets that are affecting the delivery of some critical interventions. And that is the second part of the agenda, is to examine how we can use public financing differently and the mobilization of global financing differently to address the very large failures in developing health service delivery networks, particularly in poor countries, when we see that we have a global health workers shortage. So you mentioned the work on labor market. Actually, the problem of labor market is not that far away from the question of common goods, because they are somehow the backbone of the public health infrastructure. And yet today we have a major supply side problem in which we're not producing enough health workers globally. So what is it that we are doing about this? And it's certainly right now not something that development aid can do, in the sense that the cost of investing in health workers is much larger than what aid can mobilize, even if we would use the 0.7% as the threshold of aid financing. The other aspects is infrastructure. In Africa, less than half of health facilities have water and electricity. We've seen it during Ebola. There was no water in clinics in Liberia, in Sierra Leone, in Guinea. So this investment in infrastructure, although it's not per se a common good, is actually something that will be a limitation to any public health effort and any effort to invest in public health infrastructure. And what we need to see in terms of change is move away from this charity model that we've been using in global health towards a real financing model. As I mentioned, the global health money in 2019 was 25 billion. The amount that public development banks invest overall every year is 2.7 trillion. That's public financing. I'm not talking about markets. Yet, it's only in 2020 that public development banks, most of them, suddenly discovered that there was not enough investments in public health infrastructure. We need to make the entire public financing architecture to work for these investments in health. And that means not working with a multiple type of initiatives that are just about providing short-term answers, but it is about mobilizing the entire capacity of public investment in the world towards an agenda of investment in public health infrastructure. And that is what Finance in Common, the network of public development banks, is now addressing. The day after tomorrow in Abidjan, there will be a meeting of all these public development banks to have this discussion, have a session on investments in health and social protection, and see how do we build that public health infrastructure, and how do we work with the fifth, with, of course, the fifth being there as a source of funding to incentivize and subsidize the investments in public health infrastructure, which are a global commons. And that's really this agenda shift that we all need to help happening, which is that shift from small amounts of aid to massive investments in health system infrastructure, and this shift towards this agenda that focuses on the 5 functions that are global common goods. Thank you very much.
Thank you. Thank you, Agnes. I think you raised a lot of issues. The issue about market failure is important. Is it that markets fail or markets are working and you don't like the outcome of markets? That's a subtle issue, but I agree with you on the 5 institutions. I'm just worried that the multilateral approach is going to be difficult. You know, in the G20, we only started talking about health. Actually, it was big support by Germany and France around 15 or 16, because we had the Ebola crisis. And the G7, we actually made that in 15 our primary thing. So nobody wanted to talk about health because there wasn't any problems with health perceived. So unless you have a crisis, nothing will happen in the political area. And that's why I think you should not ignore the private side, because they might be your friend, because the public side won't move unless there's like the ACTA A, which was remarkable. I would agree with that. But I agree with your 5 points, but how to get there is something we need to really think about. Okay, sorry to have taken the floor. Stephen Karingi has been waiting to deliver his speech, and we're very happy to have him here. He's the Director of Regional Trade and Integration at the UN Economic Commission for Africa, and he has been obviously somebody who has done important work in this area. Stephen, thank you for being here, and the floor is yours.
No, thank you. Thank you very much. And good evening, everyone. The good news, one of the good news that at least we have had during this conference, and I think we should be proud of, is that even though we were tested as a global community, and it's indeed we were tested, we passed in some areas and we failed in others. In Africa, we were at least able to come together, work together, and deal with, come up with solutions that at least allowed the continent to deal with the pandemic. Of course, there was solidarity that grew along the way, but there were some moments when really Africa had to come up with solutions on its own, because everybody else was also suffering from the pandemic as we have had, because it was the first time that all of us in the world were faced by this. So that's something to build on, and I think I'll come to that as I continue. But let me come and talk about the reality though. There are a lot of challenges when it comes to financing health in Africa. It's unique. Only on average about 5 to 6% of GDP of most governments or most countries go to healthcare in the continent. You have 1 or 2 that are above the 10%, but on average it's 5 to 6%. Out-of-pocket expenses by African citizens are actually more, on average, than what governments spend on healthcare. So you have about 36% of financing health in the continent coming from people's pockets, and including those in the lower, those who are below the poverty line. Then you have 35% coming from governments. And then you have about 22% that comes from external partners. So this is the reality. And so if you are, and why I'm giving these numbers is because, of course, if you are going to have a global solution, you also want Africa to be part of that solution, but you cannot be part of that solution when at the national level, most of people are the ones who are already taking care of themselves. So they may not be able to contribute. And when you're coming with a solution and you're not able to contribute, you're also not very happy. You want to be part of this solution. So that's the first point I wanted to make. Now, but this is being made worse, and I think we have also had this in terms of the financing agenda, by the fact that a lot of countries are facing debt distress. A lot of money that the governments are collecting, they are using that money to deal with, or at least to take responsibility for the interest payments because of the debt that they hold. And you can see where I'm going with this. Where I'm going with this is that maybe we do actually have some tried and tested ways. The debt suspension initiative, the debt service suspension initiative that we had previously in the last 2 years, actually about 12 months, I don't know whether it went up to 18 months, where countries were allowed not to service their debt and to use that money to deal with the pandemic. Maybe this is something that we should think a little bit more in terms of having these global solutions for global challenges, because it worked. Even though not so much money was involved, the little that was involved at least enabled those countries that were in debt distress from the low and middle income countries, and mainly the low income countries, to at least be able to deal with the pandemic. So maybe as we think about moving forward, this is an area that we should revisit. Now, the third point I want to mention is that the COVID-19 did actually magnify a lot of structural issues that exist in Africa, especially the continent's reliance on imported goods, especially imported pharmaceuticals. And I think, you know, I'm a market believer. I work on international trade. I work on regional trade and regional integration. And so I'm a firm believer of the market, and I think a lot of us here are also firm believer of international trade. But I think there is something that happened during the pandemic whereby Africa imports up to $14 billion worth of pharmaceuticals every year. It can only be able to produce 2% of its own requirements and in the pharmaceutical needs. And so the question comes whether when it comes to thinking about building resilience and security, how does the global architecture come into play in at least helping the continent deal with this challenge? Now, I'm raising this point because I think we have heard a lot about global supply chains, the sourcing of the products that are traded under this global supply chains. And it's not that Africa is not able to manufacture, medicines. In fact, in the area of HIV and AIDS, there are companies that are actually able to produce generics to deal with HIV and AIDS in the continent. Now, the only challenge is that because there is a lot of international players, especially through international aid in the field of HIV and AIDS, sometimes these companies in Africa are not able to grow because they are not able to take into the market whatever they produce at the same price at which what is being supplied under the various global initiatives to deal with HIV and AIDS. So even as we talk about global architecture, we have to ask, maybe some of this sourcing of some of these pharmaceuticals by the global institutions, especially including the UN institution, UNICEF, and also initiatives like Gavi, should we have a proportion of that is set aside at least to create a market and to create production capacities going within the continent? I think you heard about the situation of Aspen during the COVID crisis, whereby they started producing COVID vaccines, and then there were no takers. Because the way the system works is that the contracts to supply, Aspen was not part of that initiative. And this plays again in other area of pharmaceuticals. So the point I'm trying to make here is that maybe by being more bold and saying that we want to think more about resilience, security, and sacrifice a bit efficiency in terms of prices, maybe this is something that we should have on the table as we think about the future. And this resilience and this security is whereby in a continent like Africa, the international community is able to have the solidarity of at least allowing that premium, or at least taking on board that premium of a little bit more expensive dose of vaccine or a little bit more expensive dosage of a medication, so that at least you can build the supply capacity within the continent. Because we have seen the supply chains do actually collapse, and it happened. And so we cannot always bring the argument of the market. And again, I want to put a caveat that I'm a believer of the market. But I think when it comes to matters of life and death, there is, I think, some premium that we should be willing to concede, so that we can build a much more prepared population across the world, including in Africa. The other point, I have on 1 minute. Oh, 12 minutes I have finished? Okay, it's because, okay.
I haven't made a mistake, yes.
So 12 minutes are gone?
No, 1 minute.
Okay, that's fine, Lars, no problem. I think I was able to make two of the most important points I wanted to make, because I wanted to make the point about revisiting the supply chains. I also wanted to mention the issue of in dealing with debt question, because of creating the fiscus for poor countries. I talked about that. But I think I had one last point again, which is we've talked about the fifth. And Agnes is here. You are here. You are involved in the question of the special drawing rights. You have heard that of the $650 billion new SDRs that were issued during the pandemic, Africa got only 30 billion. Most of the developed countries got these SDRs, and they have parked them. In fact, you have about $180 billion of parked special drawing rights that are not being used by countries like Germany, the US, the UK. And so if we are going to think about, again, financing of the global commons, maybe we need to be a bit more innovative on how we use some of these global money, the special drawing rights in this particular case, whereby in order to bring down the cost at which developing countries go to the market, in order for them to be able to finance their budgets, because of course they go to the market because they cannot be able to produce, to have a revenue take for everything they want to do. Maybe we need again to think about this global architecture global financing architecture, the role of special drawing rights and how you use them as part of building this new international architecture for health resilience and health security. Yeah.
Great.
Thank you. Oh, 12 minutes are so short.
Yeah, thank you.
But thank you.
The special drawing rights actually was one of the most difficult things for me, because Germany does not participate because of our legal rules, because the special drawing rights are with the central bank, and the government cannot decide on these special drawing rights. The whole world can allocate them except for Germany. So that was at the G20 when we talked about that, a very difficult thing. But it's also easy money, actually. It's just printing, central bank. It's not really, it's easy commitment. And that's why I think a lot of the rich countries like to give special drawing rights, because it doesn't have budgetary implications for any of us. And Germany actually can't do it. So we actually took some money into our budget. So we actually had to use our budget, whereas the rest of the world just used the special drawing rights. So it's good it's there, and it should be allocated efficiently, but it's not really a big commitment on that. I think it's supply stupid. A lot of these problems are supply problems. And I think you should use the market and not fight the market, as you said. Let's take 3 questions from the floor. I also have one and then we'll try to collectively. Are there, let me get up. Are there mics, or how do we? I can't see you very well because it's the person here. There's a lady in the front, another lady on the side, and take a 4th one, the gentleman in the back. Start with the gentleman in the back because you're there. Faster. Please, short and crisp. Thank you.
Right. Thank you very much, and a good afternoon to all of us. I think looking at global goals for health, as we have listened to the various eminent speakers, we are considering situations of how to take care of the health of the world's population. And here we are looking at a certain critical social sector. My question is, if you look at 2 critical social sectors, education, health, it would appear that most countries probably have leverage better in education. Health is a challenge. Here I call for leadership, as we have heard here, coordination, and to look at the commodities space. How much do we need to be able to deliver the goods, to deliver quality health service? And I'm happy that one of the speakers even mentioned about health workforce, for instance. Even though we may not look at it as a commodity, but the limitation of health personnel across the globe, which is causing the shifts. The same thing as the health commodities proper, how they are causing the shift. Can we look at that, leverage a certain leadership, and ensure that we have enough, not just a financing, but enough? Thank you.
Thank you. Thanks for the panel. My name is Sebastian Schöneher, infectious disease clinician from Leipzig University and global health researcher. Ms. Terrell made a great point saying that the most beautiful medical innovation isn't worth anything if populations in need can't access it, and I couldn't agree more. And you've also mentioned how much public funding went into critically needed vaccines. Same is true for other medicines where we see market failure. And then once we have a product, we again have to negotiate to actually, get a price that is affordable. So what I'm wondering, why don't we consider intellectual property a public good? Shouldn't we do that? And maybe how can we think earlier on in the funding process already about access that we need in the end? Yeah, thank you.
Hi, I'm Melissa Shavai. I'm here for Doctors Without Borders, MSF. Thank you so much for all your presence. for your presentations. Yes, I'm speaking for myself, also for my organization. I very much agree with the analysis of the market failure that we're seeing also in the COVID-19 pandemics. But I was surprised of your analysis that we need to build new institutions to correct the market failures. I would think that we have a lot of institutions already, and our governments also have a responsibility to correct the market failures that we're seeing. So kind of adding to the question actually that was put before me, I would be curious about your views of then what is the role of the government, actually the governments that we have, of giving power to the already existing institutions to correct these market failures. Thank you very much.
Thank you. It's Emma Ross from Chatham House. This is for Agnes, I think. When you were talking about shifting to public health infrastructure funding, were you distinguishing public health infrastructure from health systems strengthening? I don't know if those two terms are being conflated. Were you meaning everything? Or are we talking about surveillance, laboratory capacity, or are we talking about traditional health system strengthening in the guise of, the UHC movement type of thing? Because there are a lot of competing demands for this money, and I just was looking for clarity on your vision.
Yeah, thank you very much, Stephen. I think your 12 minutes really passed quickly. So I just wanted to specifically ask you, because you also, I'm Dr. Jan-Peter Böttcher from GIZ. I just wanted to ask you, you spoke about regulating the market, which I agree it's absolutely necessary to build an African pharma and medical market. On the other hand, what do you think of pooled procurement from the African side? Thank you.
Okay, before I give every one of you one question, also two questions. Same question from Altair. I just read this. It's not a surprise. When will we finally launch an international debate on the temporary waiver of intellectual property? This was discussed in ways before. I was actually very involved in that because my boss had a very strong view on that relate to common global goods, saving lives and protecting the world, notably in times of crisis such as the historic pandemic. Should we wait for the next pandemic to learn more about those failures? So the famous TRIPS waiver discussion from the floor. Maybe we'll start over here and we'll end with Stephen. Agnes, would you like to respond to some of these, please?
It seems to me on this particular question that first, it's a perfect illustration of a global public good, which is to have a global mechanism that is a regulatory mechanism. It's a regulation function that is global, and we have the WTO and we have other UN institutions that can contribute. It is a question of building collective action and building consensus. Now, what is the nature of those TRIPS agreement is the product of what is supposed to be a global democratic debate. And this is where, so I mentioned in my presentation the concept of market failure, but there is a concept of bureaucratic failure and failure of collective action. And you mentioned the question of the tragedy of the common. No, it's Rajat who mentioned the tragedy of the common. The tragedy of the common is the tragedy of collective action. It is much more difficult to create a collective action than to just go and buy your baguette at the baker shop, at the bakery, right? So that's the tragedy of collective action, and it's more difficult to have collective action for 7 billion people than it is for just your neighborhood. And that's where we have a problem, is we need to elicit a democratic consensus on global regulation like TRIPS, and it's difficult.
What about the education question, since you've done work in labor markets?
So
remember the question about education and health?
The question about, yes, the question about education. First, I would not be sure that education did better because if you look at the results over the past years, we actually have 80% of children aged 12 in developing countries that have suboptimal capacity in reading and computing numbers, while actually the health outcomes have been improving over the past 20 years. But what you are highlighting is, yes, the question is how much value do societies give to health and education, and how do we build collective action to fund these sectors through collective financing. And what is worrying in health is that over the past 20 years, the allocation to health by governments in low-income and low-middle-income countries has declined. So in fact, low-income and low-middle-income countries spend less on health than 20 years ago as a proportion of total budget.
So I will try to address two questions that are related to the public health institutions, I think colleague and the colleague from Chatham as well. So first of all, true that in many countries of the world, especially in LMICs, the format of a public health institution exists. However, from a functional standpoint, it's very poor. You have people who in title are supposed to do stuff, but they're not doing it. The infrastructure is there, this is not there. The systems are not there. So definitely, I don't think that Agnes wanted to duplicate or suggested that we duplicate whatever is there, but rather than strengthening the functions, the operation, the processes, and there's a great need to that. Now, going back to your question about HSS, health system strengthening, and public health institutions, I see those having separate functions, but an overlapping something, and overlapping in between. But they are separate. You don't expect health systems in a classical sense of UHC to be able to do proper population surveillance, because that's not their job. You don't expect them to sort of support the vaccination production, because they're more into, mostly the acute aspects with a little bit of prevention. So the prevention population-based has to be with strong public health institutions. Definitely they collaborate, but there are also separate functions.
Thank you. Rajat.
Very briefly, I think the responses to the questions have already been provided by Agnes and Shadi. Just a couple of things to underscore. One is we haven't quite talked and gone into the detail about some of the reforms that we are thinking which are being proposed. One clear one is the intellectual properties reform, and what would that look like, and something that Agnes has unpacked for us. But the other is also the global taxation and the financial flows, and how do we bring some sense of financial viability into the conversation, which is not happening right now within the present systems of architecture. So to go back to my MSF colleague, I think you are absolutely right. We're not talking about junking the institutions that exist, but overhauling the institutions where they need reform and actually substituting where the gaps are. And this is where I think the conversation went a little bit too quickly on what are the challenges and where are the gaps in terms of how do we move the conversation from a very siloed vertical model of global aid to something which is focusing on global health financing and building the global health financial architecture. I think we need to look a bit more deeper than these 90 minutes have allowed us. And there is a lot that is happening right now. But I want to end with that particular point, and multiple people talked about it, so why we haven't done that. And I think there has been a collective failure of leadership. And this is where I think we do need to go back, because a lot of these issues that have been portrayed in front of us right now on what are the 5 interventions and where are the critical actions, that does require leadership. And I think this is one of the big casualties, as was witnessed multiple times, and how we rebuild the trust and the leadership is where it'll all come back.
Stephen.
And yes, I actually had that point on pool procurement in my notes, but when Lars told me it's time, I jumped it. Yes, one of the solutions that was very useful during the pandemic for the continent was basically the pool procurement approach. The African Medical Supplies Platform that many of you may have heard about was actually predicated on a mechanism where there was an aggregation of demand by African governments, and on the basis of that demand and that kind of order book, the continent was able to negotiate very good prices. And then, of course, it had a logistics system to distribute that. Before I came for this session, we were having a conversation where we are trying now to see how can we build on this, because now we are having the African Continental Free Trade Area, which is going to level the playing field and create one market within the continent. And so we are asking ourselves, how do you ensure that Madagascar does not pay 10 times what Kenya and Ethiopia pays for oxytocin? Because that is what the data is. Now, the only way you can be able to do that is if you can bring these countries together. They pool procure together. But the more interesting part of this is that you also create a demand and build a market, especially within the continent, because now you have this order book. So I just want to agree with you. We need to have pool procurement systems that work within the continent, but even globally. And part of this, part of the ordering of whatever is going to go to the order book and the pool procurement, we think that it should be fairly distributed. So we also want to see some of these orders of pool procurement also being placed with manufacturers in developing countries, including Africa. Thank you.
Yeah, thank you very much. I think we're out of time. I think that a lot of good points have been made, both on the governance side, the 5 points, and also on the financing side. And the ACTA A COVAX, I was there, was, I think, to a large extent an initiative which was supported very much by the G20 under Saudi presidentship, by the way, with big support from President Macron, I might say also the Chancellor, and others. There was a world crisis, and the G20 actually delivered. There were so many problems with trade and other nationalism afterwards, but it was, I think, a good moment. Now, if you think about all those important issues and how to take it forward, the governance issues, you know more about this than I do, and then say there's a failure of leadership, which is in a way true, but leaders are just leaders, and they're not all bad, actually. I mean, some of them are very good, but they respond naturally. The world comes together when there's a crisis, okay? And I think that we need to keep pushing these multilateral initiatives, but the world is sort of, we're going in a different direction, Ukraine and all kinds of things. And health might be actually one of those subjects, this is what we kept saying for the last 5 or 6 years, where it's important. It's very, very important for the people. It's important even for the economy, because people said the G20 is about the economy. It's not about health. I say, well, the health is also about the economy. And it's something where the world has to come together. So a practical way forward, this year's Indonesia, but it's a difficult year for the G20. They probably won't have a communique because, the Europeans insist on something on Ukraine, which is not going to happen. We have 3 developing countries. Next year, it's India. Mr. Kant is the Sherpa. He's at minister level, was just appointed by Modi. So the Indians are probably thinking about what they do next year. So to the extent that you have influence on that, and they must be already very far advanced, try to put health on the agenda for next year. And the country after that is Brazil, which is in the middle of an election campaign, where I think health will also play an important role. I think it's playing an important role in the election campaign right now. So my suggestion would be, let's try to move into that direction, and then hope there will be leadership. And the other point is, and again, I can see why this is a sensitive point. I think that if in the absence of a crisis, I mean, we have a crisis in many ways already, but big things were number one topic in the world was COVID for 2 years. Every G7, G20 was always COVID. It's the private sector who's doing things. Now, of course, you have the market failure issue. They're interested in making money. But I think using the private sector in some of these models is probably another way to keep things going, to the extent there's a role for the private sector, and I do think there is. Okay, so let me thank you again for all of this. This has been fascinating. Sorry for going over a little bit, and enjoy the rest of the conference. Thank you.